if we need to go somewhere quick and we need to get there really fast, this is the most light and fastest setup that we have.
Okay.
So it's the dirtiest too. So we try to keep things as clean as we can and meet Canadian standards. So we also have another tending system that has a floor attached inside of it, so that's a cleaner environment. We also have another container that's like a sea container that you'd have on the ships, and it's a fold-down pop-up tent. So the sides fold out. All of the canvas is secured to the sides, and we just put poles in. It has running water capability, has electrical, it has air conditioning, and heaters inside of it. And we can do air conditioning, but because of all the holes and cracks and leaks, it's not very seal tight.
Okay, so how hot can it get?
It depends on your environment, and it's a little bit hotter than it is with your outside environment.
If you're in Afghanistan in one of these tents, are you basically boiling?
We're not in Afghanistan with these tents.
Okay.
We're in Afghanistan with what we call the MTS.
Okay.
And it is that half moon tent with it's a sealed environment. So it takes it down, and it is a workable environment. I don't know the exact temperature, but I'm fairly comfortable in there when I'm scrubbed up. I'm an operating room technician, so I'm scrubbed in the OR. When I'm scrubbed up and I have all my gown on and everything, I'm a comfortable temperature where I'm not profusely sweating, I'm just warm. Yes, we do help civilian casualties somewhat, and they would be determined and come into us. So I don't make those decisions. I just work in the tent, and as they come in, then our higher up in command structure would make the decision on who's treatable and who's not. Come in, then they get the same care as everybody else, and we have doctors that are trained for pediatrics. We have anesthesiologists trained pediatrics, and then we have our surgeons who can look after pediatric patients as well.
But you didn't have to deal with any little kids.
Thank you.
Okay. And you were going to take us all the way through so we know what you guys actually do every day.
Sure.
Thank you so much, Dr. Park.
So, our field ambulance would be an ambulance on the further from the battle situation. So we have med techs, and we have other more rugged ambulances that are right at the battle situation. So they're transporting the patients from the battle to a more safe, secure location. We will bring our ambulance to that location, pick the patients up, and bring them back to us that's further away from the battle.
Now, how much protection do you have in one of these ambulances?
Not much protection, so that's where we're further away from the battle. If we are worried about with landmines and that, then we could use a Buffalo or an armored protected vehicle to carry the casualties in that. In the resus bay, we would have 2 stretchers come in at a time.
Okay.
And we can do anything like an emergency room in a hospital. So we do vital signs. We do heart rate, temperature, pulse. We have a team of approximately 5 or 6 people, each with a task. So one is doing vital signs. If its injury is worse, they would start an IV, and they would be able to do intravenous. We may catheterize them. We would do a full head-to-toe assessment. If they are injured in a certain area where they're saying painful leg, we would do x-ray. So we have an x-ray machine. The x-ray machine is digital, so it goes off onto a digital monitor. We have radiologists in the forces. We do not have many, so they do not deploy for a full deployment all the time. We have the capability of sending a satellite back to Halifax in Canada, have a radiologist there do the diagnosis, and beam the diagnosis back to us.
How long does that take?
I'm not exactly sure. It's fairly quick. It's within hours or a day.
And if it's like a broken leg, you see it on the digital screen, even if you're not a radiologist, would you treat it as a broken leg?
And yes, the doctors, the surgeons can make that decision. The radiologist is the ultimate decision maker, that he's had the long schooling to make the ultimate, this is the diagnosis. And so yes, we would treat it and confirm our diagnosis with the radiologist. Here, they make the decision. Do they need to go straight to surgery? Do they need to go to the ICU? Do they need to go to the ward? And so from here, they made that decision. So we'll move on to the OR. Operating room. We typically, with one advanced care surgical center, we have one OR.
Okay.
We can do any surgeries that you can do in a regular hospital. However, our mandate is life, limb, and eye. So we have a 72-hour holding policy. So we try to take care of their life or their limbs or their eyes within 72 hours and get them back out into a more definitive area of care, of more further away from the battle.
Okay.
So we would be putting in external fixation. So if they have a fracture, we would put a rod in on top of the fracture, the bottom of the fracture, and put a metal bar across to stabilize the fracture, and then move them out. So then we're not putting pins and screws and causing infection.
And that makes sense. And a lot of times when we report on different cases on the mainland, it seems like there's a lot of surgeries going on for certain injuries. This explains why there's so many different surgeries at times.
There is. Part of the job with the operating room is the trays. We carry all different types of trays. We have orthopedic trays, we have general trays. We bring a central sterilizing unit with us and CSR, and we have 2 sterilizers there. So in the CSR, we have 2 sterilizers, and we'll sterilize all of our trays and kill our bacteria in the trays, so we can continue with surgeries over and over and over. The sterilizer, they come onto a drying rack. From here, they go back into the OR. They come back into the CSR. They would be washed, wrapped, sterilized, drying rack.
And how long does that process take?
It takes us, depending how dirty they are, 20 minutes to wash them, another 10 to 15 minutes to wrap them, 30 minutes to sterilize them, about 10 minutes to vent the sterilizer, 20 minutes to dry, another 10 minutes to crack it, then they're ready to go. If we need an instrument right away, we can take a single instrument, put it in the sterilizer, sterilize it 3 minutes, bring it out hot with a sterile technique, cool it, and use it right away. So the ICU, we carry 5 ICU beds with each ASC. This would be our recovery area for people coming out of surgery. So that's making sure that they're breathing and they have no complications from the surgery right away. We can look after seriously ill patients with a ventilator, and this machine would breathe for the patient. We have a hotline and a ranger. We have a bear hugger, which will keep patients warm if they're hypovolemic. We have a vital signs monitor, so we can do blood pressure, pulse, and we can do temperature. So these are for our seriously sick patients, and it's 1 nurse per 1 bed. Again, going to that 72 hours out, so we can maintain function of taking care of seriously injured people. We have ward bed. The ward bed, we carry 10 ward beds. Again, we would take care of their vital signs, dressings, changes. Typically, the ward beds would be for any people that are sick with infections. Then we can take care of them on a short duration and get them back out into the battlefield. So that's a typical hospital. What we're planning on doing is keeping it down to a short stay, taking care of life, limb, and eyes, and getting them back to a more definitive care area.
Okay. Thank you very much.